Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. All right, welcome back to the Breast Cancer Podcast, where we explore the latest insights in women's health, and we will talk about cancer prevention, cancer treatment. And I'm your host, Dr. Deepa Halaharvi. And today I'm super excited to have Dr. Kelli Rath. She's an amazing GYN oncologist. And like myself, her passion is educating the community. And she does a lot of these podcasts. She's very involved with the health system she's currently working at. And you do a lot of education, and you do such a beautiful job. So it's such an honor to have you here today.
Thank you for inviting me.
Yeah,
Really
thank you
appreciate
so much. Thank you. And this episode is going to be exciting. Now we are going to be combining the gynecological cancers, the breast cancer, the similarities, the differences, and how we treat each one of them. And so I wanted to start asking you again, thank you for being here today.
Of course.
And how often do you see patients who have both gynecological cancer as well as breast cancers?
Right. So it's not as it's pretty common.
Yeah.
Breast cancer being so common.
Yeah.
1 in 8 women, I think. I treat women with cancer, so
Yeah.
I do see a lot of women that have both a gynecologic cancer and a breast
Yeah.
cancer. We know that the BRCA genes are the most kind of common genetic or inherited risk factor or reason that people might have, both the most. And there are many other, BRCA 1 and 2 is kind of where it started.
Yeah.
And now when I do genetic testing, I'm testing like 77 genes. And so there's more than we could ever cover in our time today. But so we know that BRCA 1 and 2 increase your risk of both breast and ovarian cancer, as well as for men also. Patients always say to me, oh, do my sons need to get tested? And I'm like, yes, because there's cancers for men as well. So I would say it's pretty common to have women who have both. Sometimes it's genetic, sometimes it's non-genetic, but something we see very commonly.
Yeah. I typically say the same thing for, BRCA 1 and 2 is very commonly linked with the GYN, with the ovarian cancer as well as the breast cancer. There's also HNPCC or the Lynch syndrome. Do you see patients with that?
So it's much less common. It's interesting. Almost 25% of women with ovarian cancer may have a genetic predisposition. Lynch syndrome or HNPCC is more common with uterine cancer, a much lower risk of ovarian cancer, and a much less common gene for people to carry. Also increases people's risk of colon cancer.
That's right. That's correct.
That's big cancer that we see with that one.
And very small amount of breast cancers are seen with that. Not common. But like you were alluding to earlier, less than 10% of the people who get diagnosed with cancer have a genetic mutation. Would you say that same for the GYN
cancer?
It
is, except for ovarian is a little more common. And so anybody that's diagnosed with ovarian cancer or has a first degree relative that has had that, first or second, so grandma, aunt, cousin, mom, sister. If you have one of those people, then you would qualify for genetic testing because it's a little bit more common than some of the other cancers.
Yes. We say family history of ovarian cancer, you need to get tested for genetics. And if you have family history of 2 or more breast cancers, male breast cancer, multiple colorectal cancers, pancreatic cancers, prostate cancers, these are all indications for genetic testing.
Correct.
So you want to be
Yep.
aware of that. So again, going back
Mhm.
on the same thing,
Mhm.
family history, how does that influence one's risk of getting cancer?
Right. So we know that it can be genetic, right?
Yeah.
And we said it's kind of less,
Yeah.
10% of cancers are genetic. And so always knowing your family history, bringing it up to your primary care doc if that's who you're seeing, and
Yeah.
saying, hey, I've had these people in
Yeah.
my family had a history of cancer. I'd really like to have testing.
Yeah.
Testing is so much more easier to get covered than it used to be by
Yeah.
insurance. There's protections about after you have testing, keeping your insurance and things. People always ask me about that. And I think the other thing that's exciting is there's so many things to do with the results of those testing now.
Yeah.
We really change how we screen or
Yeah.
what things we might recommend for risk reduction. We also know that sometimes family history is positive and we do genetic testing and we don't find anything.
Right.
And so then we always wonder, is there something genetically that we're missing? Was there a gene that we don't know about yet?
Yeah.
Or is it an exposure thing? Is
Yeah.
this family having different exposures than another family? And so we still need to have our antennas up. I don't know if that's the right thing to say. Are paying attention to symptoms and making sure the screening is there, even if the genetic testing may not show what we would expect based on family history.
Right.
Yeah.
We always say, like, with the family history, like, for instance, my genetic testing was negative. My daughter, unfortunately, is still at a higher risk of developing breast cancer because of me, even though genetic testing is negative.
Exactly.
So your risk is still high. So you still want to, go to doctors and keep your appointments and getting imaging depending on what age you are. So let's talk a little bit about prevention. And for these high-risk gynecological cancers, what can they do?
Right. So unfortunately, there's no good screening for ovarian cancer. Even if the highest risk patients, it doesn't seem like, we always talk about doing ultrasounds. People always ask me, like, should I get the CA125 blood test? The CA125 blood test is hopeful, but it's not going to be the silver bullet to find a stage 1 ovarian cancer. And that's what we find, even combining ultrasounds and CA125s, we're really not able to catch these cancers in stage 1. We think a lot of them are actually probably starting in the fallopian tubes. And it's a teeny little bit of cells, and then they start spreading before there's a mass or anything for us to see. And that's why it's so challenging. And so that's why when you do have a genetic predisposition and we know that there's a significantly increased risk of ovarian cancer or fallopian tube cancer, we recommend surgical risk reduction. So removing the fallopian tubes and ovaries between ages 35 and 40, kind of depending on the gene, depending on the family history, is the best thing that we can do to prevent these cancers in the highest risk patients.
So then I think this is a good time to bring up hormone replacement therapy, right? So for these young women, BRCA patients, BRCA 1 or 2, they're so young, and we are recommending prophylactic removal or preventative removal of the ovaries and the fallopian tubes. That's where the ovarian cancer starts. What can we do for them?
Right. And so there was a time that we weren't really giving anybody hormone replacement therapy. And when we talk about hormone replacement therapy, we're mostly talking about estrogen.
Right.
And so there was a large trial that came out kind of in the mid 2000s that was really saying, gosh, there's all these risks associated with hormone replacement therapy. And as we've done more research, more deep dives into this, it seems like hormone replacement therapy is probably important and helpful for the majority of patients that have to have their tubes and ovaries out at a young age. We know that when women have their ovaries out before age 50, they have actually a decreased overall survival. Obviously, if they have a breast or ovarian cancer, and that's why it came out, that would be different. But this is just all comers, benign reasons for hysterectomy, non-cancerous. And so using hormone replacement therapy helps with quality of life. It protects bones, prevents hot flashes, helps with vaginal dryness, so many things. And so it is safe for the majority of patients that have this done, as long as they don't have a personal history of breast cancer.
So, the WHI study, which you alluded to earlier, that's a hot topic right now for women, for hormone replacement therapy as women are going through menopause. And I think that's a different population. Today, we are talking about patients, either they've had ovarian cancer or breast cancer, or they have a genetic mutation, such as a BRCA mutation, which, there's a recommendation to have preventative removal of the ovaries. So for those young women who have uterus still intact, but you're just removing the fallopian tubes and the ovaries.
Right.
What type of hormone replacement therapy would you give them?
If your uterus is still intact, you're going to need both estrogen and progesterone.
Correct.
Because if you're going to do estrogen by itself, it can stimulate the lining of the uterus and actually increase the risk of uterine cancer. And so by using the estrogen and the progesterone together, the estrogen is giving you those good benefits as far as hot flashes, vaginal dryness, all of that. And then the progesterone is protecting the lining of the uterus. For the majority of patients, if we do keep their uterus intact, we'll do a hormone replacing or releasing IUD, so Mirena or progesterone releasing IUD to protect the lining of the uterus. And that kind of prevents the need for systemic progesterone that can have risks. I would say many of my patients that are having risk reducing surgery, especially if we're going to do hormone replacement therapy, a lot of times we'll do a hysterectomy at the same time, just to prevent the need for another medication, another treatment.
Right. That makes so much sense for me. So for those women who've had breast cancer, like myself, I've had a hormone positive breast cancer. And so what would be, I'm still premenopausal, what would be what would you recommend for me for hormone replacement therapy when I do go through menopause?
Yeah, so typically those are the patients that we don't recommend systemic hormone replacement therapy for at all. And so doing things like, making sure you're exercising, good protein, lifting weights, doing those things to protect your bones because, we won't be using estrogen as you go through menopause systemically. But, vaginal estrogen is typically safe if there is trouble with like the genitourinary syndrome of menopause, vaginal dryness, painful urination, increasing urinary tract infections. But then there's other things that we can use also many times, like other lubricants or other topical things, vaginal DHEA, other things like that can be really helpful. And so really finding a practitioner, whether that be a doctor, nurse practitioner, APP that really is experienced in taking care of women that can't use systemic hormone replacement therapy to really make sure that we're taking care of all the things that happen during that transition and keeping you a whole person.
I love you because you're so much about quality of life. And I think it's important.
It is.
Unfortunately, cancer happens to us, but that doesn't mean we cannot still have good quality of life.
Exactly.
Sometimes it just takes a little bit of time, a little bit of talking to your doctors and your APPs to figure out what would be the right thing for you.
Exactly.
For a person who's at a higher risk for breast cancer, and I think we touched on this just a little bit ago, we would recommend MRIs alternating with mammograms and twice a year clinician exams. For ovarian cancer, you said there's not really a whole good
there
testing.
isn't. So before, we do the risk reducing surgery, which is kind of the gold standard. Certainly I do follow women with ultrasounds and CO125s in my office. And we usually do that every 6 months. It's hard because every month our ovaries ovulate. They make a cyst that's normal. And so kind of defining what's a normal cyst, what's an abnormal cyst, and then kind of following the trend of the CA125 is a thing we do, making sure that people are paying attention to their body, recognizing any symptoms. Symptoms that we look out for would be like urinary symptoms. So feeling like you're going to the bathroom more often than normally or not emptying your bladder all the way. Pelvic pain, abdominal bloating, not being able to eat a full meal. So kind of really keeping a close eye on those things.
So this is for the ovarian
cancers. Yeah.
So that's good to know, looking out for those symptoms.
Looking for those symptoms for ovarian and then doing the ultrasounds and CO125s and kind of continuing to have a conversation. There's one thing, we have a trial open now. We're looking at could we just be taking out fallopian tubes early and not be taking out the ovaries? Because like I said earlier, I alluded to a lot of these start in the ends of the fallopian tubes. Right. And so if we're able to take out the fallopian tubes, which doesn't have any hormonal impact, we may be able to keep ovaries intact longer. And, maybe 10, 15 years we'll be sitting here saying, oh, we don't have to take out your ovaries so early anymore. You can keep that good hormone and help you stay healthy and whole.
Yeah. I know the recommendations for BRCA1 and 2 are a little bit different. The BRCA1, the recommendation is between 35 and 40, and for BRCA2 is 40 to 45. Now it makes sense as to why the recommendations are a little bit later age. So that's really good to know. I know when people want tubal ligation or don't want to have kids anymore, I did have Dr. Anita Somani, who was on this podcast before, talked about that, about removing the fallopian tubes to decrease the risk of developing ovarian cancer.
We really encourage, instead of just burning or clipping the tubes, taking the tube all the way out. Or, if you're having a surgery for another reason, there's some people that advocate just like, let's get those fallopian tubes out of there so that we don't have that risk.
Yeah.
Yeah.
And before I started talking
Mhm.
about all the questions
Yeah.
here, I was asking you, what type of surgeries do you perform, just for our audience?
Yeah. So I take care of women who have ovarian cancer, uterine cancer, fallopian tube cancer, vaginal, vulvar cancer. So a lot of hysterectomies for uterine cancer. With ovarian cancer, we do kind of the larger surgeries when it's spread. So whatever needs to be done, bowel surgery, kind of, it's a really amazing
Yeah.
job. I get to really be with women throughout the whole thing. And then I also do chemotherapy.
Yeah.
So not
Yeah.
only do I do surgery for those
Yeah.
cancers, I do the chemotherapy for my patients also,
Yeah.
which just really lets you, I think that's why, quality of life,
Yeah.
I really see kind of how that impacts
Yeah.
people, right? I meet
Yeah.
them when they're diagnosed,
Yeah.
surgery, chemo, and then I'm with them kind of
Yeah.
as they recover from
Yeah.
that. So
Yeah. You really get to see from diagnosis to treatment to
yeah,
survivorship to thrivership.
exactly.
And so you get to help them and be part of their,
Whole
journey.
journey.
Yeah. Yeah.
Exactly.
And
Yep.
you're such a great physician. We've had a lot of mutual patients.
Yes.
I've had nothing but great things that,
Yeah,
people
same.
talk about you. So thank you so much.
Mhm.
I know we have used tamoxifen for
Mhm.
women to decrease the risk of developing breast cancer
Right.
for those patients
Mhm.
with genetic mutation, or
Right.
if they have atypical ductal or lobular hyperplasia.
Right.
I know we always talk about a little bit of risk of endometrial cancer. Have you
Yeah.
seen that?
So it can
Yeah.
happen.
Yeah.
We know that tamoxifen is kind
Yeah.
of a selective estrogen receptor
Yeah.
modulator. And so it acts differently in the uterus
Correct.
versus the breast.
Yeah.
The majority of these cancers that happen are early stage. And so keeping an eye out for any abnormal bleeding, it's not a huge risk. It's a pretty low risk. Usually the benefit that people are getting from the breast cancer reduction
Yeah.
far outweighs any risk from the
Yeah.
uterus.
Yeah.
And so just making sure if you're taking it, that you know what symptoms to look for and
Yeah.
that you get in to see your gynecologist if you notice
Yeah.
anything.
Yeah. That's awesome. Let's see. We talked about the hormonal factors
Yeah.
and what are some long-term considerations for women who have survived gynecologic cancers?
Yeah. Gosh.
Like, I guess, survivorship issues, sort of.
Yeah. I mean, there's so many. I
There's
think
so
they're
many,
similar, with
to the breast.
breast
Yeah.
and and GYN cancers. For GYN cancers, a lot of times we'll use pelvic radiation.
Yeah.
Just like I know you guys use radiation
for
for
the breast,
breast.
yeah.
And so a lot of times after pelvic radiation, people will have a lot of kind of pelvic symptoms.
Yeah.
We've taken away their estrogen.
Yeah.
So those tissues are estrogen deprived. Then they've been treated with radiation,
Yeah.
which can cause some fibrosis.
Yeah.
So a lot of my patients will end up having kind of some chronic pelvic pain with intercourse, vaginal dryness,
Yeah.
vulvar symptoms. And so a lot of them will end up getting pelvic floor physical therapy,
Yeah.
vaginal estrogen, like lots of different things like that.
Yeah.
I think would be the biggest thing we see
Yeah.
that's a little different than what you see in the breast cancer
Yes,
population.
yes. We breast cancer patients also have sexual dysfunction
Right.
problems, vaginal dryness, pain with intercourse, and the new normal is so different. Kate
Exactly.
Middleton talks about this most recently. She came out and said, the journey after the treatment is completed, it's so difficult.
It really is.
And that's the whole reason this podcast was created, is finding your new normal, is finding what works for you and talking to your providers, figuring out what works for the vaginal dryness. There's moisturizers, there's lubricants, there's vaginal estrogen that's now been studied and is safe for breast cancer patients to use
which is so great.
which is so wonderful
great
for
for
quality
them.
of
Yes.
life. And then physical therapy is a huge thing for breast cancer patients, right? So whether it's lymphedema from X dissection or from a pelvic floor radiation in dysfunction and things like that. So
exactly. And so really just like you said, I think finding your new normal, knowing that you'll never be the same person that you were before, just like any life event, and kind of harnessing that and finding like, where does this next path take you, and how can you be the best version of the person you are today?
Yeah, absolutely. And that's why I think these conversations are so important. And this podcast would not be doing what it's doing right now without experts like you coming in, giving your valuable, advice and information and knowledge, and sharing your knowledge. So, Dr. Rath, anything else that you would want to add to today's conversation?
Gosh, I could
You
talk
could go on and on for a long time, because you're so knowledgeable in the topics.
I just think that, knowing your family history, knowing your body, going to the doctor, if something doesn't seem right, letting your doctor know. I think the one thing I didn't talk about is abnormal bleeding in uterine cancer, right?
Yes.
So we don't have any screening
Yes.
for uterine cancer. It is the most common GYN cancer,
Yeah.
and it typically presents with irregular bleeding,
Yeah.
either irregular premenopausal bleeding or postmenopausal bleeding.
Yeah.
So after you go through menopause, bleeding isn't normal.
Yeah.
Many times also, if you're still having periods in your late 50s,
Yeah.
that may or may not be normal. And so
Yeah.
if you're experiencing those things, recognizing them and getting in to see somebody
Yeah.
is so
Yeah.
important.
We covered breast cancer, we covered ovarian
Mhm.
cancer, uterine, anything
Yeah.
for the vaginal cancer, any
Vaginal
symptoms?
cancer is incredibly
Yeah.
rare.
Yeah.
Gosh, I think there's only 1,000 or 2,000 cases a
Yeah.
year.
Okay.
Many times HPV related.
Okay.
Symptom of that would be irregular bleeding.
Yeah.
So pretty
Yeah.
much I always say if you're bleeding after menopause or you're bleeding outside of a normal period, or you're not having periods at all and you're only 35, gosh, those are all reasons to see your gynecologist,
Yeah.
have a conversation, get an exam, figure it out.
Yeah.
Is this a cancer?
Yeah.
Gosh, there's so many things that aren't cancer that cause those things
Right.
also.
Right.
But they all need treatment.
Yeah.
Yeah.
Awesome. Well, thank you so much. And you're completely right. Be your own advocate,
Mhm.
know your health, get screenings. I think we cannot emphasize that enough.
Exactly.
And thank you so much for joining us today on
of
this
course.
topic of gynecological cancers and breast cancer.
Mhm.
They are connected. And we hope that you found this podcast useful. And if you did, please share it, give us a 5-star rating. And that's what keeps it going. And I could not do this without experts like Dr. Rath. And I'm incredibly grateful and honored that you are here today.
Well, thank you so much for inviting me
thank you.
anytime. Love to share information.
Thank you so much. Take care. Until next time.
Bye.
Bye-bye. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer, this podcast is not intended for complete medical advice, so please talk to your medical professionals.